Good evening, and welcome to The Caring View, the online health and social care platform that is free, yes, free for everybody to access. Before we get started, don't forget to hit subscribe, hit those like buttons, get sharing, invite people to come and watch. Follow us on Facebook, LinkedIn, X, and wherever else we might be. Find our podcast on Spotify and all your favorite podcasting sites. And if all of that's too much to remember, go to www.thecaringview.co.uk and you can get everything from there, including free resources that come out every single week and a list of suppliers that we love. They're tried and tested and they're absolutely great people. So if you're looking for HR or for workplace management or anything at all, go and have a look and there will be stuff on there for you. Before we get started, though, just a reminder, we will not be live next Tuesday. It is the Care Show at the Birmingham NEC, and I mean, we're ecstatic for it. We've got 4 Caring View talks while we're there, 3 in the Care Managers Theatre, 1 on the keynote where HSBC will be joining us all around employee and employer financial well-being, and we've got 2 fabulous sponsors. Which I've had a very long day, so forgive me. Mark, I'm going to pass that over to you. Who are our sponsors?
Yes, so we've got the fabulous Paula Cashmore and White's Training that have sponsored us this year, which is great. It just means that we can kind of give back to the people that we've got joining us on that stage and just give out some goodies to people that are joining, which is always nice. So I think sometimes, and I say it all the time, a lot of people that attend don't realise that the people doing the talks aren't there being paid. They're giving up their own time, often taking annual leave to pass on their wisdom and their thoughts. So actually, it's nice just to give a little something back for that time. So, yes.
Absolutely, 100%. So tonight, I know you may be watching this and thinking, this is all about the women. Well, men, pause and have a think about this, you guys out there, because the menopause affects us all. And who better to come and talk to us tonight about the menopause but Jacqui McBurnie. Jacqui, welcome back to the show. Just for the viewers who may not have watched this before or have seen you before, just give us an insight into who you are and what you do.
Thanks, guys. Thanks for asking me back. My name's Jacqui McBurnie, and I work in NHS England, which is the kind of policy health sector. I am a nurse, and I founded and chair the NHS Menopause Network, which is across England, and welcomes our NHS colleagues and our social care colleagues for both formal and informal training, awareness, and developing the conversation around this, challenging some of the myths that we probably should cover tonight.
I mean, fantastic. And a hands up. I mean, I know more about it now since I've started doing the Caring View, but I feel awful because I've had to go out and find out about the menopause. I've had to go out and find out the information and find out how I can support my teams better and how I can support other people better. And then I know, I'm from a same-sex relationship, so it's just never going to happen in this house. It's, never going to happen. So I'm not going to experience it. I've got a mother going through it and I just think she's possessed half the time. But it's not something that I've got first-hand experience with. Mark, what's your experience around knowledge of the menopause?
I think other than some of the work that we've done in the workplace, not much. And it was a conversation that I really wanted to have on the show. And I remember this time, it must have been just over a year ago. And I remember we had booked somebody in and then I was admitted to hospital. And I remember messaging you being like, this is like the worst timing ever because it's a real conversation that I really want to have. So I'm really pleased that you've agreed to join, Jacqui, just to impart some wisdom and just share some easy tips that providers can implement into their day-to-day services.
Is it worth just covering the first myth, which is that the menopause, I think at the beginning, we picked up about gender straight away. Let's just get into that a little bit more. So the menopause is about ovaries, and it's about hormones. It doesn't really matter what gender you are or don't want to be or don't recognise as. If you're born with ovaries, however you live, recognise yourself and find yourself to be in, those ovaries will be the reasons why you might have symptoms and might have to navigate some of this, might experience some challenges, and might need to seek some support, either formally or informally, to manage some of those symptoms. So the ovaries produce the sex hormones, and the reduction of those sex hormones are the reason that we see some symptoms appear.
I think it's so important that you brought that up, because it's, you know, and let's not get into politics. We had a really good chunter before the show went. Well, I did. I just went on a tirade like I normally do, and I'm being professional now, so I won't do it live on air anymore. However, there are conversations up there with the powers that be around genders and safe spaces for people, and actually, the complexities of gender and identification around gender are huge, like absolutely huge. So we've got terms like AFAB, and if people don't know what AFAB is, it's assigned female at birth, and that's the gender you're assigned at when you're born, which is fine. People who are assigned female at birth may decide that actually they identify as male and live their lives as male. If they don't get rid of those ovaries, the chances are they still will have symptoms of the menopause, depending on what treatments they go down and how they go down their gender reassignments. We also have people who are born intersex, you know, and actually the complexities of intersex people and having multiple sexual organs, it's nothing to be ashamed about. Fabulous people. You know, we've got to move away from this idea that people are different, because there is no such thing as normal. So when we talk about these things, it's so important that we respect everyone and we make everyone feel included, even down to things like accessibility. And it's something that I talk about quite a lot around accessibility to information. You know, and the first thing we say is, do you have any accessibility needs? And even that in itself isolates people into thinking, well, there's a normal and I'm not that normal, so these are needs that are different to everyone else's, when actually our language needs to shift towards more, how do you access information? Because how do you access information removes the idea of a norm and actually takes everything on board. So do you have ovaries? Yes. Okay. You may suffer from the menopause. It's not, are you a woman? And that's by no means, and I know this is cheap coming from a white man, my sound booth thingy. I have the gay card, fine, but I am a white man talking about women's problems and women's health. But this isn't removing the safety of women at all. It's just making sure that everyone who's going to go through this gets the support they need. Am I right in that, Jacqui? Am I hitting the park? Oh my gosh, Mark's changed my name to Alan. He's an absolute. Anyway,
I was wondering when you'd noticed that. I was trying not to say Alan. Thanks, Alan. Adam. So I think it's a really, really important point that we take away, and it's not to remove the aspects or the sensitivities or safe spaces of any group. But if we take this as a hormonal issue, which it is, then everybody's included in this, because even if you won't experience it directly in terms of your own body, you will experience it because you work with somebody that might, because you have a family member or a friend or colleague or relation that might have those issues happening, those experiences, and may want either permission to talk about this or permission just to, you know, make somebody aware or seek support or even signposting. So either as colleagues, as friends, as line managers, it's really good to just take away any sort of stigma attached. Make it about what it is. It's a natural process that is an ovarian hormonal issue. And then, okay, if you need support, there are some good resources here, and here that are clinically validated, or that perhaps recognise in the way that you recognise, so would speak to you, or indeed culturally or racially look like you. And all of those layers add to the sensitivity and the accessibility that is really important, because it is, as we've kind of said, it's so individual, so multi-layered.
And I suppose it's just a reminder for anyone who is listening to this and trying to get things right. There are conversations happening right now within government which are isolating to people in our communities, and they are isolating of communities on various different topics. It's just a reminder that they're not right. And just because they're the ones in the hot seat saying these things doesn't mean that we should just follow suit. We know in our heart of hearts that actually the best thing to do is to be inclusive of everyone. And I think if we just follow what we're supposed to do, I think the benefits for our teams and the benefits for the people we support will shine through. And I think that's just important for us to be aware of.
Just on the touching there on where to start, I think there'll be a lot of providers out there that we know that subscribe to a policy company, so they'll have had a menopause policy just pushed out and it will just be very generic. They might not be doing anything else. Where would be a good place to start for a manager or a provider when they're looking at menopause? What should they kind of touch on first, or what should they encompass, Jacqui?
There's a whole range of things from culture to openness to respecting people's dignity and privacy to not share, as well as those that need permission to share, all the way through to formally having sessions that teach us about menopause and what it is and what it isn't. So a whole raft of things there that come through all the way through to from one-to-ones and conversations in the office that aren't kind of allowing those microaggressions or, insensitive comments all the way through to this is the clinical rationale, these are the symptoms that might present. And as line managers, we might want to, for instance, look at uniform or look at workplace or work pattern flexibilities. So there's a whole range. But I guess the first thing to start with is having the awareness ourselves around what it is, what it isn't, and then opening up the conversation. And that might be as simple as in a group or in a one-to-one, particularly saying to someone, "Are you okay? You look a bit tired since I last saw you. How are things?" Sometimes we all get a bit run down. Is it worth having a chat with your GP or nurse? And not making it about the menopause or targeting about a particular thing. And then it's completely inclusive, completely open for that individual. But it's like, "Oh, you okay? Have you slept all right? You look a bit, So things like that don't necessarily have to get into the specifics. I don't know how that would land.
No, I think that's a really great point, because the last thing we want people to do is go away from this going, right, another tick box exercise. Have we covered the menopause? But actually, it just melds into absolutely everything. And if we just look after people and genuinely are concerned about them and support them and have that space where they feel that they can open up and they can talk about what's going on in their lives, I think super important. You mentioned about microaggressions, and actually it's about understanding microaggressions across the board. And if as a company we have really robust DEI or EDI, however you want to say it, policies and procedures and cultures, then hopefully microaggressions don't exist. But if they do, we can pinpoint them and we can try and eradicate them within our services. And then it should encompass approaches to the menopause as well. Before we get on to myth number 2, Jacqui, we've had a question come in, and I will bring it up for you. And it's, Jacqui, what's your view on the menopause and the work charter?
Do we mean official in terms of is there I know that the formal all-party political group, the APPG, has made a recommendation that employers with a given number of staff have a formal policy. Is that what we mean? I'm just going back to Tina's question.
I've just typed it into Google in the background, and it says the Menopause and Work Charter is an initiative of the European Menopause and Andropause Society, EMES, to promote recognition and consideration of menopausal health in the workplace.
So that is something that that the Menopause Mandate, or APPG, as it's formally kind of stood up, it's a cross-party group, is keen to progress so that employers will be required to implement and embed policy. And I think that is a good idea. In principle, it gives a framework around recognition to employees of that aspect, but also then gives a kind of a start to conversations. But policies are only as good as how embedded they are, and they often get almost, there's like a middle management layer. And I've recently done a listening clinic in a hospital provider trust whereby some of the staff were met with let's say it wasn't as well received as the top of the organization would describe it to be. So the operational level, there was a bit of a mismatch there. So I think it's great, but it's got to be the lived experience. And the bit around my role as network chair is to say, that's great, but what's the lived experience of those operational staff on a day-to-day? And how are they thriving at work and well and keeping patients safe? Yeah, thanks for that. That's the APPG. And Carolyn Harris is MP for Swansea and is leading and stood that APPG up. So there's a lot of work happening on that.
And I think it's so timely as well, because especially in my neck of the woods up here in northwest Lancashire, we've got an ever increasing aging workforce, which is fantastic. You know, I think it's great. It's brilliant to be able to provide a new career pathway to people in the later years of their life. Fantastic. Yeah. And I know we'll get onto a myth at some point, which will talk about age and the menopause. I just know that's that. I can see you getting prepared with that. But it does increase our probabilities of having a workforce which is going through the menopause. So we need these robust procedures and policies in place and embedded and part of our culture and communicated so that we can support them moving forwards. With that, do you want to go on to the myth of age and menopause, Jacqui?
I'm trying to get in there. Yeah. So menopause doesn't come with it an age. And if you quote, the average age for menopause in England is 51 years, to somebody that is currently struggling with it, they might not thank you for that. If they're 12 years in or 20 years in, they might throw something across the room in frustration. So I'm waiting for comments to agree with me in the chat on that. So colleagues of mine in the network, we have a small group of early menopause. So early menopause is typically 40 and below. So you can have a menopause at 18, you can have a menopause at 23 or 40 years, and it's just because it is. Sometimes that is chemically or surgically induced. So you might have a hysterectomy or you might have medicine that brings that forward. In just parking the chemical and the medical and surgical aspects, sometimes it just happens. Now, any colleague that would be in early menopause, so somebody in their 30s, for example, could be part of your team, and would then have additional aspects to manage that perhaps might be 18 years longer than someone that had a natural menopause. So what we would want to do is to support that colleague, and obviously they should have excellent support through their GP and specialist services, but their bones, their joints, their cardiovascular system, for example, all of those additional long-term health benefits we would want to maximize so that they can still thrive at work and be physical and mobile and all of those things, so that they're happy and as productive and let's say thriving, I suppose, as well as they can be and should be. So it's really important to think about that, because when we talk about policy, and it's great to have the awareness and the embedding to support colleagues, we also really need colleagues to be fit and well. So we know the gaps that we have in health and social care. And certainly in my Royal College, the Royal College of Nursing, Royal College of Midwifery, we know that we can't recruit our way out of this gap, staffing issues. We know the same for social care. We need to value those staff and keep them mobile and fit for as long as we can, because inside those individuals is decision-making, experience, organizational memory, and they're also critically the mentors and teachers of any new staff we try and keep hold on to that come in as well.
So, oh, go on, Adam.
No, you go.
Oh, no, I was just going to talk about, you obviously spoke there about the staff and how many people it'll impact. Is there anything that the employee should do for themselves? Is there anything they should take onus on?
Firstly, in terms of the employee, I am really in two minds as to whether we expect that employee to share that status, that aspect of what they're going through. Personally, it's very personal. Personally, for me, I think it's up to them. And I think as organizations, we need to respect that, particularly if somebody's gender is not as we would. So if they identify as male in the workplace, why would we expect and demand them to declare they're having menopausal symptoms if that is not how they believe themselves to be? They recognize as a man they are. That would be effectively outing someone. Some organizations would push the issue for colleagues to declare with line managers that aspect, but I don't particularly support that. Certainly for the individual, it's great to have a list of resources for them to access for themselves. It's also great to have peer-to-peer informal support if they can access that. And there are other wellbeing activities they can do themselves. Things like diet, things like being mobile, things like trying to continue flexibility, balance, all of that kind of exercise, movement. And there's a lot of research now with Professor Tim Spector and the Zoe app, looking at specifically around menopause, the way fat distribution changes at menopause. So people could do their own research that way and look at, what can I eat differently? How can I minimize any potential change in my cardiovascular disease risk, my diabetes disease risk? All of those things can be done by the individual. So we talk about HRT, hormonal replacement therapy, but there are a huge range of things that are also really important in the toolkit.
You speak there about the Zoe app. Is there anything that's on the market that you know of, or any apps that are cheaper or that do a very similar thing? Because obviously I don't obviously have the Zoe app, but I know that it's obviously on par with a mobile phone contract, and you obviously pay monthly for it. And I didn't know if you knew if there was anything else for obviously people struggling that wouldn't be able to afford that kind of monthly fee.
Well, there are symptoms trackers that are around there, and Dr. Louise Newson has a Balance website and a Balance app. The Balance app is a symptoms tracker that will give information too, but the Balance website is free and you can access a library of resources and podcasts in that to look at everything from the basics all the way through to particular aspects with, for instance, any impact from the psychological symptoms on mental health and well-being. Critically, they are also in a number of languages too, which is really fantastic. And if your accessibility isn't really great through loads of written words and you prefer a spoken conversation, that's a really nice way to access the information that way too. The British Menopause Society also has small snippets of recordings on BMS TV. They are menopause experts nationally, and they're also a short 4-minute, 5-minute recording with a clinical expert that is also offering that way to access information. So as many different opportunities to access in different ways is always great. So there are a number of free things there. In terms of health and food, I think you can access the podcast from Professor Tim Spector and the Zoe team without signing up to the app. So you can access that way and have the podcast either written or spoken as well. So loads to look at.
Okay, so I'm an employer, let's say. I get now that it can hit different age groups. It's not just defined as one age group. And I know all this stuff's available. Can I rest easy? Are all the symptoms the same? Does everyone experience it the same? Can I just go, oh, I know what I'm looking for, and I can spot it really easy?
Absolutely not. So every single one of us will have our own level of functionality, our own kind of status with our hormones. When I say status, I mean status quo. So that obviously extends through menopause as well. So our situation is both very unique in terms of our age and level of symptoms. Some people don't declare any symptoms at all, and others would say their symptoms are extremely intrusive and bothersome is actually the term for it, and would say that is significantly impacting on their day-to-day life, and obviously there are some legal cases testing that as we might go through shortly. So the issue in terms of symptoms and severity and age is also important for your racial heritage.
I was going to ask whether we had cultural
Yeah.
intricacies to consider through all of this.
We do, and that's something I really, really would like to just get into. If there's anyone on the call that wants to share in the questions box. So there was a study. It was ages ago. So I'd really like for kind of upcoming research, and certainly I'll be asking colleagues for this to refresh. The study was called the SWAN study, and it was a US study. So SWANN, and it looked at racial heritage. So all the diversity across the states was explored in terms of their experience, their age, and onset of symptoms around the menopause. And it found that women of colour, particularly Black women, had early symptoms and they had more extreme hot flushes for more years. And women of Pakistani heritage or South Asian would declare symptoms of the menopause earlier as well. So that's another question around, let's not look at averages. None of us are average. Let's look at what's unique to that individual in terms of their genetic profile, their makeup, how they arrive at that menopause. But then also what's important to know is that some of those women studied here that we're looking at will also already have a disadvantage in terms of their experience of healthcare. So we know that treatment or perception around pain scores access to medical support, and even they would probably say, colleagues say this to me, being believed and validated in terms of their experience, their pain threshold, their pain score. If you have all of that, and then you come into the menopause at the age of 38 with symptoms, and your GP perhaps says, oh, you're too young, let's look at something else, and does a number of tests, delays perhaps access to hormonal replacement therapy that you might have asked for. And this is obviously, just a scenario, but taking that average age and then excluding that someone, or, them not accessing treatment is a problem. So we potentially need to remove that average and look at the historical factor and the data and take people at face value and explore that racial heritage and in more detail.
And just on the racial heritage, again, I'll act ignorant on this, but I know menstruation has different approaches in different cultures and different communities.
Yeah.
Right or wrong, I'm not making comment on that at all. Is that the same with the menopause? Are there different cultural not interpretations, approaches, the ways that? Yes, that's correct. Yes. And is that something we should be looking? I will say this: the best thing about the UK is it's multicolored and it's amazing. It's so vibrant and it's so different and it's so unique, and it's built on so many different cultures, which is incredible. But actually, if we're trying to get our heads around this, do we need to be considering cultural differences that aren't physical?
We absolutely do, and obviously my background is NHS, and one of the best things about the NHS is it's not built on the white male middle class person. It's everyone that that's kind of grafting in it, of every different diversity. So that makes us all so richer and more fantastic, and that's one of the benefits of having a network of everybody across NHS and thankfully more recently social care, is that those aspects come in. And that was back to my point about lived experience, because we can have any number of policies, any number of guidelines and training and whatever, but if that lived experience is like, well, that never happened to me, I was shooed away, or I wasn't believed, or that wasn't my experience, then we haven't met the needs of that person. So I hear a lot that women of colour, particularly with older relatives, can't discuss this. So I have a lot of conversations around, again, the Pakistani heritage group of ladies that say it's tricky. It's not as bad as it was. Things have totally changed, and it's not everybody. But some of my colleagues say they are assumed to have closer family ties, assumed to have closer connections and more open conversations. But on this topic, it's a no-no. So where do they go for that informal networking, or that, did it happen to my auntie at my age? Is this normal for my family? Did my mum have an early menopause? She's not here to ask. If I ask my auntie, will she talk to me? No, she won't. So it's all of those things that perhaps we need to go back to our older female relatives and ask. And the same thing, a friend of mine is from Zimbabwe, and she is not, they are not happy to share either. And I think it perhaps goes back to the power of informal peer-to-peer support, but also finding a group or connecting with somebody that looks like you as well, because there will be some things that will be easier accessible or easier understood because that person gets it from that area, or their family come from that area, and it's like, oh yeah, mine won't talk about that either. It's really kind of just breaking down those barriers, opening that up. But it's so many layers, this topic, and women still say, oh, it's taboo, which is kind of a shame because it's going to happen whether you like it or not. And there's no end date. So, you know, we kind of need to navigate through it.
We definitely still have a bit of the prude. Sorry.
No, go on.
It was just one comment. I was just going to say we definitely still have a bit of a prudish, upper lip British attitude post-war going on, don't we? You know, all you have to do is say sex and people go red in the face and like, oh, can we talk about this? And actually in health and social care, yeah, we talk about sex all the time, just FYI. So it's around removing that prudishness and that stigma around it, isn't it? And actually it's just a word, it's just a physical condition that your body goes through. You'll talk about having diarrhea quite often if you want to get a day off work. So talking about the menopause should be easy.
Yeah, that's what I was going to say. It's very. Why do we think there is that taboo around? Because it's commonly spoken about, isn't it? Like you see it on the internet, you see it on social media, it's on the feeds, and yeah, it's not like some of the other taboos we have that just isn't kind of openly discussed. Do you know where some of those taboos come from, Jacqui or Adam?
Yeah, I think traditionally it was wrapped up in your worth, value, role, function. And obviously in some cultures, like Wales, for instance, Wales have a menopause, and the older whales, the female whales lead.
Sorry, are we talking about the country or the animal here? I got really
confused. The animal. The whale leads the pod. They have a menopause, and they are seen as the respected elders, and they are valued for that role. Now, if you have a perception that, oh, well, I'm finished, and remember years ago at menopause, we were nearly dead. So, you know, you didn't live that long. You didn't need to work to get your pension for another 20 years or whatever. And you didn't want to start your exciting retirement plan or bucket list or whatever after menopause. So it has a connotation of end of fertility, therefore, are you functional, are you useful? Perhaps has all of the connotations around less flexibility, being grumpy, being in pain, being less tolerant, all of that kind of negativity, because actually we were finishing a lot of things at the same time, working, child production, child rearing, you know, whereas now around menopause, we might have child responsibilities. 25% of us might be a carer in some way or other. We will work longer and probably work more years in our peri and postmenopausal phase than we are fertile, because we've got to work longer for our pensions anyway. Some of us absolutely want to and want to carry on and run businesses and thrive. So there's a lot of negativity that was attached to it that I think we're shaking off more and more. And, you know, love or loathe Davina McCall, she's done a lot for the topic of menopause and just breaking that down a little bit. So
she's doing a lot for double denim at the moment as well. Every time I see her, she's wearing double denim.
Well, there's a crime.
Yeah, I know, right? Stonewashed as well. Can you believe? No, I'm hearing those, and I definitely feel that, especially in Western societies, we still have this idea of women as this sexual icon. You are here for one reason and one reason only, and it's to appeal to the male gaze, to birth as our kin, and then look after everything. And we see it in films. You know, I'll pick the newest Tom Cruise Maverick, Top Gun, whatever it's called, film. And he's back, you know, he's in his 60s and he's looking at it no matter what anyone else says. Female co-stars, no, let's get him a new, younger, hotter model. Yeah. And let's use the women in media to portray that this is what it's like to be a woman at this age and this is what it should be like. It's all sex and this and that. And I definitely feel there is an element of, once you've hit your menopause, you have lost your worth, which is atrocious, really. But I see that more in Western society than probably in the Eastern parts of the world, and it's a hard thing to shake, and we've got a lot of work to be able to do on it. So no, I agree on that side of the stigma. It's just interesting for us to figure out where it's going wrong and actually how do we change this now moving forward with the newer generations coming in. how do we start changing this now, and how do we start shaming people who have those sort of old-fashioned views and go, look, it's wrong. That's not what it is.
Yeah, I wonder whether some of that will naturally change with the younger generation not focusing on having children or careers and wanting to have that work-life balance, and actually where they're saying, actually, I don't want to have children, actually removes that whole stigma, actually, that you're not worthy after you're obviously after the menopause, because naturally they're not bothered by that anyway.
And
I don't know, a ton of young Tories in question time at the moment in the audience, so that idea of it being generational concerns me.
But I think there's, if you also take that working life being longer as a kind of lifespan thing, we also don't have one career either. So there might be a lot to be said for that kind of younger generation coming through with different mindsets of, actually, I might go traveling at 50 and take a few years off and then come back again, or retrain or something. And they don't have that, and they sometimes just don't have just one job either. There's not that kind of rigidity that we had when I first came into nursing. And then also there's the aspect of people will do more work that feeds their soul as well. So they'll be leaving employers and do things to seek out what makes them happy or fulfilled, or at least do that on the side. So there's a little bit more movement and openness, I think. People are more aware than we used to hear about.
Off you go, Mark, sorry.
No, one thing I had written down when you were talking earlier, well, I wrote a couple of things down, but one of them was uniforms. So my workplace has just gone through kind of consultation with some of the female staff that were on the menopause working group and looked at uniforms. I was just interested to hear kind of your take on what uniforms should be, whether they should be a certain colour, whether they should have certain fits, or what have you seen from some of the people in the APPG working group?
So uniforms are a big issue because we need them. We need patients to be able to recognise them as well and feel comfortable and safe around that. That's a really clear kind of, I understand what that person does. And we also need to be comfortable because we're in them a lot, and functional. A lot of my nursing colleagues have the opportunity to wear less fitted outfits, so more kind of air through. Some of them have the opportunity to wear scrubs, which they sometimes like, so it's a little bit of hit and miss, but they don't like light colors. So if somebody has the symptom of heavy bleeding, they absolutely would not want to be in any situation, especially, for instance, if it was somebody doing domiciliary care in somebody's house or doing house to house to house, somebody having to drive to and then support somebody at home and then drive on. That would be really, really tricky and difficult. So we often hear that colleagues get provided additional uniforms to be able to support that and keep their dignity, and also looser fit. So things like that are always helpful, and just to be able to ask for that and not look different, and make sure that's not a justified kind of position. You don't have to justify it. It's fine. It's a given. Is usually helpful.
Yeah, I was going to say, because around the uniform angle, the last thing we want is to have basically a big badge going, I'm going through the menopause. Yeah. Look at me wearing this. And again, though, it's a case of actually, would the most inclusive thing be able to come up with a variety of uniforms that anyone can access and use and be a part of, just so that if they don't want to be open and honest about that with everyone, which they don't need to be, they can have that confidential conversation. It's a very personal thing, but it looks no different because anyone can choose. We've got people who will struggle in hot heat and will have excessive sweating. They probably won't want to wear something light coloured, even though it's probably going to be better on them than something dark, but out of worries of being embarrassed. So maybe we should just have a look at uniforms in general and make them as comfortable and as accessible as we can for everyone.
Yeah.
I often look kind of back at my time in learning disabilities, and there is no uniform in learning disability. You rock up in whatever clothes you want. And I do often think, actually, in older people's care homes, could that not be something that could be implemented? Because that's very uniform based, isn't it? But I know there's a number of domiciliary care companies in my area where there is no uniform, because actually they say that if you're supporting somebody that's vulnerable, you're knocking on their door, you're highlighting straight away that you're a carer going in. And actually, if you just turn up in your plain clothes, you would never know.
And that's a consultation we went through when I managed a home care company and a care home. And for the care home, and I will admit, menopause never even came into my head, Jacqui, so slap my wrists. But our thinking was, I know, that was more my head mark. Yeah. Our thinking was for the care home is we're touting this idea that it's a home from home. Oh, look at this, you're in your own home now. And we're walking around in clinical clothing, and it just doesn't feel like a home. It felt institutional. So we got rid of them in the care home for that reason. And for home care, the exact same thing Mark's just said is 7 o'clock every single day, someone rocking up on the doorstep in a nurse's uniform or a carer's uniform just screams vulnerability. And actually, it was a huge concern for us. So we got rid of them, especially because we were an isolated rural community. But actually, what it allowed team members to do was wear stuff that was comfortable for them. So in summer, we weren't getting people going, oh, can we have lighter uniforms, or can we try something cooler? They could just wear it. You know, if they were going through physical problems, or if they were going through pregnancy, they just had clothes that they had that they were able to wear and utilize. Completely different for healthcare. I understand it, NHS, hospitals, and all of that. But in social care, we have got this wonderful position where actually maybe we do have a bit more flexibility around the uniform scenario with multiple reasons and benefits to the impact of the people we're supporting and who work with us.
No, and I think that's a great point, because there are often arguments around, oh, well, health attracts, you know, the staff and keeps them, and social care is almost like the poor relative or whatever. But that's actually something that you could say, tell us about that. Tell us what works for you. Tell us the feedback on that. Does wearing your own clothes make you feel more considered and more connected to the organisation, because we give you that flexibility? And, you know, it's a respect thing. So that's, you know, a real positive.
Yeah,
so one thing we can't control, well, some of us have control, but a lot of people wouldn't, especially in healthcare, would be around the environment. And that was the other thing I wrote back. Are there any environmental changes that workplaces can implement to benefit people going through the menopause?
So I often have a look at policies for organisations, and one of the consistent things in those policies that talk about flexibilities and what we should do as an organisation is access to cool drinking water. It's kind of always been there. It's always been there. There's no really, you know, it's not a real selling point to put that in, and it certainly isn't going to keep staff, in my view. Obviously, that's different when you're out on the road doing domiciliary care. But in terms of, you like the structure of the organisation, the office, or that type of thing, or
I think
offices, restrooms, workplace, sort of rec rooms, and I'd even go as far as saying, you know, so our organisation does Wellbeing Wednesday, and it's wonderful and it's fantastic, and the majority of our homes are now adopting it. And I think it's one of the most amazing things is supporting our team members to look after their own well-being. But for me, well-being is also about having those difficult conversations at times.
Right.
And if we've got smokers, is it something as an organisation we should provide every now and then to go, oh, by the way, these are the benefits of quitting smoking, and these are sort of things that you can do and you can do to support yourself, and maybe we can improve how we do things at work to support you through this. Is there stuff we can do that around the menopause? Any sort of wellbeing sessions, guidance sessions, or like Mark said, anything structurally that we should be thinking about? Summers are only getting hotter, like really unbearably, stiflingly hot. And I'm still waiting for the government to come out with a bursary for providers to put air cons in all care homes. I think it's going to happen sooner rather than later. But with that in mind, is the stuff we should be considering moving forwards?
I think there are certain things depending on the work requirements of individuals. So things like walking meetings are helpful. Be outside for 40 minutes or however long and walk the meeting on the phone if you can. Have some light into your brain during the day. Things like team meetings and I appreciate, you know, protecting breaks and whatever, but can you eat lunch together, or can groups encourage that? Are there opportunities to have hygiene, changes of clothes in the loos? So things like that, things like wipes, things like, you know,
providing a shower, maybe.
Exactly. One of the hospitals I worked with had a black cardigan, so a couple of black cardigans in the ladies' toilet, and it was actually only the ladies' toilet. They'd just put it in there, and it was meant to be something that somebody could tie around the waist if they had an accidental bleed start to happen. Tie it around the waist, go out to the car or access their own change of clothes or whatever, and then replace the cardigan when they could. So small things like that, I thought that was really quite insightful. So little things around dignity and things like that in the loos. Yes, showers if possible, lockers if possible, or a locker that's designated perhaps as menopausal support locker. You know, that's just one locker then people can go and access if they need, or a small shelf or something. And they could decide what goes on that shelf. They could decide how they build that support shelf or locker. So that's a really good one to get people involved, get people's own insight to what they think. And then obviously things like fans do help. Some people do get quite hot, and controlling temperature can be an issue for lots of people. Even self-rostering can be really, really helpful to some people, just to have that sense of control. If you just can't sleep, you know, you might want to look at what time of the day works for you to be at your best.
Yeah. And I always say this whenever we come up with benefits for team members, and check it with your tax people, because I don't want to get you all in trouble, but having an extra supply of feminine hygiene products in various sort of capacities and sizes, just in case they've packed and they don't think, you know, they're going to have enough to get through the day, just have them on site so people can access them in emergencies. You know, it's super important.
Tax. Surely it can just come out your petty cash, the same as you buy your tea, your coffee for yourself.
I know, but HMRC, they're run by blooming Ebenezer Scrooges, aren't they? Everything's tax incentives nowadays, and you've got to be careful, haven't you?
Ask a charity. Ask the civil servants charity or whoever to come and do it for free, or write to Boots or Superdrug. They'll provide it. You know, do all that stuff. They'll do some for free, and then put their banners and stickers up and say, you know, this is how we do it. Put it out on social. You know, thanks to Superdrug for providing or supporting this. I would, but I don't know the rules about that. I don't know if you're breaking any rules.
So, are there any other myths we need to be addressing, Jacqui, when it comes to the menopause?
It doesn't have to be all negative. Some people really find their way and find their voice. That voice might be a teeny bit grumpy at times till they get kind of into it, but it can also be a really freeing and valuable time that, you know, you let things go behind. Perhaps you don't have so many responsibilities or, you know, issues as before. You might be more informed about your own health. You might be more informed to be equipped for your own well-being. You might appreciate where you've come to and where you know the opportunities next. You might also be more informed about your body, especially back to that comment before about if you were assigned female birth but don't recognize that way, you might get to a point where you think, you know what, I'm great, I'm fine, I am what I am, I'm here. You might be more body positive at this time. because you've done that knowledge, because you've come to that place. So it can be a really freeing, positive time as well. And we've talked a bit about the symptoms, a lot about the symptoms, but there are positives too.
So I'm going to ask this because I know Mark wants to talk about this, and I'm just going to be provocative. If someone goes off sick, can I sack them?
It depends what they've gone off sick for.
With the menopause. I'm just trying to be controversial to bring in the current case going on in Leicester, because I know this is something that Mark's informed me about this, so it's something new to me.
It's a really interesting one, actually, Adam, because Maria Rooney worked for Leicester Council. She was a social worker, and she worked there for an age, and she felt that she had to leave the organisation because the symptoms of the menopause she experienced were at the level where they were intruding on her activities of daily living. So she took the case forward in terms of her dismissal, and it was upheld in her favour because the symptoms did intrude on activities of daily living to the extent where it met the disability criteria, because critically menopause doesn't come with an end date. So usually and frequently we see cases come forward with age and gender, and that in that instance, even though it was voted down by the government to be a protected characteristic in its own distinct right last year, it wasn't taken forward as a protected characteristic. It was tested in age and gender anyway. So this case passed on disability as well. So Maria Rooney now is being supported by the Equality Health, I can't remember the full title of the organisation, but it's in court at the moment to go all the way through to test that in law to determine, is this a disability in her case. So it's potentially huge because it hasn't been taken this far. It's gone through tribunal cases for age and gender. So should this be an issue, then and it meets the criteria for a disability, then we have a potential significant proportion of the population that might also consider their case meets the criteria for disability.
And I wonder whether we'll then see it as a protected characteristic, because you did touch on something, Adam, there, because I know obviously I wanted to touch on it, and I did wonder whether you can treat it the same as any other sickness. Actually, if you use the Bradford factor in your organisation, can you treat it? If you've had 3 bouts of sickness, can you then, start formal proceedings with somebody?
It would be interesting to defend that, because we would know, for example, that other long-term conditions that, for instance, don't have an end date, we would be very cautious about doing that with, and we would put in occupational health support and various other things. But, menopause would have to be treated in the same way. So it's a really difficult one. And to be really sure as well, not all organisations commission occupational health services with a menopause component. And the focus on Occy Health is usually preventative or return to work. Menopause doesn't typically fit very well into either of those, or other than looking at workplace flexibilities, adjustments, and that level of work. And then afterwards, the focus on return to work. But menopause, unless it's relieved symptomatically, isn't going to be recovered. It's not like a surgery, is it? So it's a difficult one.
Do you think it should be a protected characteristic?
Personally, I do, because and not everyone has symptoms, but I think the symptoms of menopause are taking women out of the workplace, are creating all sorts of performance complications in the workplace that aren't performance, their well-being. I think it's causing pressures on somebody that doesn't recognise as a woman in this instance, that might have real struggles to get good support and care for symptoms. So I think the symptoms of menopause merit protection, or we'll lose people and we will cause mental trauma to people. So kind of the same thing, but we're damaging people and we're losing valuable people. So I do actually.
And I wonder what that will look like for other sectors. Obviously, health and social care recruits so many females, but actually, if it's a protected characteristic in another sector, actually, will they employ as many females as potentially they do now? Because obviously, we see a lower uptake in people employing disabled people and other people with, the protected characteristics. What that will look like going forward.
And given that at the moment, the NHS declares almost 80% of a female workforce, about half of those are in the typical menopause bracket cohort. So about half the staff are not going to have a choice about this. And the greater we create awareness, the more people might say, hang on a minute, you didn't respect my flexibility request or my ask for a reasonable adjustment or flexibility here. And given awareness, and people might call that out more. So creating awareness also creates a platform and a voice.
Yeah. As long as people don't think, oh, look at the Pandora's box we've opened now, and actually realize that it's probably the right thing to do. I can't believe we've been talking for an hour already.
Yeah.
As always, we are just scratching the surface. Now, I have one thing that we've not brought up yet, but I think is important for us to understand. And it's just reminded me, Mark, when you were saying about this movement to become more disability positive in our organizations. It's 100% right. We should be doing it. We should have done it years ago. We live and learn. But actually, when it comes to menopause, and we've got people who don't communicate in ways that we might be used to communicating in, how do we support people with communications that differ from ours? Or who, especially, so, maybe we need to do a session around menopause within social care and the people we're supporting, because there are many people living in care who will be going through the menopause. Yeah. And will be verbally non-communicative. It might be non-communicative in a number of different ways.
Yeah.
And we may only have certain tells. How do we support them? How do we help recognize those symptoms and provide care in that sort of holistic way? Not a question for snacks. We don't have the time. I'm not ignoring it. And I think, Mark, let's get a show booked and let's get that talking around. Maybe we can get Mencap on with us as well. And we can talk with Mencap. But it's once you start talking about it, you realize the actual ramifications of this. Half the population, if not more, are going to be affected by this. So why are we still talking about it in ifs, buts, and maybes? Why is it not something that is just ingrained within society? To sound a little bit sexist here, if we've been speaking about some of the symptoms about women being grumpy, men don't get the menopause. So what's our excuse? We don't look at men and go, oh, grumpy time of the month. We're just grumpy sods all the time. So actually, I think we should just avoid bringing up grumpiness with women going through the menopause. It's entitled. You're entitled to. You put up with straight cisgendered white men ruling the world. I know you said the NHS is built on colour and fantastics, but it's run by the white guys that always run it still. So, who are we to talk? Who are we to pass judgment?
Yeah, we've loads to do. Yeah.
Let's get Davina on a double denim. In fact, next show I'm going to wear double denim just for Davina.
Wear Davina back. She was a good sport at the previous event in Birmingham, actually.
Yeah, she really was.
Very well received, actually. Yeah, she was.
Mark, any final thoughts?
No, nothing for me. I think thinking about kind of future shows, I think that we should get somebody like Sonia on from a HR perspective and do a show around, actually what the HR and legal perspectives of, supporting somebody through the menopause. This trial will obviously have kind of run on by then, and we'll know more about the precedent it sets. But would love to do a show on the lived experience.
And the complexity around performance aspects, performance management, and that would be a great show. Yeah, great call for that. Yeah. Yeah.
Jacqui, any final parting words of wisdom for people who are realizing that actually their procedures, their policies, their approaches aren't as robust as they need to be? What's your final starting point for people? People watching this going, right, I'm going to go do this tomorrow. Where do we start?
With a listening exercise. Ask your staff, what do you need? What do you see? What do you think about if you think about leaving us? Start with that.
Spot on. That's what I'm going to be doing tomorrow. No, I've got way too much on tomorrow that to be starting on a new project. And I'm sure our policies are nice and robust. But I think really, really great tips and a conversation that we should all just be having every single day as part of everything that we do, and building into supervisions, all of that sort of stuff, making sure that people are holistically supported. No matter what they're going through in their life, I think it's really, really important. And it always goes back to the times where I used to get really grumpy at people who didn't wave. Like when you're driving and you let them pass and they don't wave. I used to go, oh God, well, you're welcome. But then I used to think to myself, actually, do I do it for a thanks, or do I do it because it's the right thing to do? And what's going on in their life? They've probably got stuff going on because they're all, it's scary actually when you think about how many people are alive at any one time. And you think about how much is going on in your life, times that by nearly 8 billion. And that's going on every single day. We have no idea what's going on in other people's lives. So it doesn't take long to just be kind and considerate and just to think, maybe they're going through something I'm not aware of. Maybe I should just sit down and talk to them. Maybe we should just say, how are you? Let's get a conversation going. So listening exercises, everybody tomorrow, that is your homework. Ready for the next show. Make sure you've done your listening exercises. Look, Jacqui, absolutely fab to have you on. You're always welcome here at The Caring View. And I'm hoping we'll be able to catch up in person again at some point soon. Everyone listening, this has been The Caring View, www.thecaringview.co.uk. Go and check on our previous podcast series. We've got a new podcast series starting in October. It's 3 episodes long. It's fabulous. There's some real great tidbits in there, and it's all around the DSPT. No yawning, no groaning. We have to do it every single year, but we've got a podcast direct from the people who support the DSPT to make it easier for you. All going to be starting from Monday next week, and it will run for 3 weeks. And our Freebie Fridays will coincide, and we'll provide you resources to help getting plans in place to get approaching standards met. And if you want to show off exceeding standards, it's going to be a really, really good show. So check out that on our podcast. Until then, we will see you in a fortnight's time, unless you're going to be at the Care Show. Take care, God bless, and we'll see you soon.
See you later.